Okay, hi everyone. My name is Zoha Mian. I'm a fourth-year medical student at the University of Louisville School of Medicine. I'm the Advocacy and Policy Director of Open Globe Talk, and I'm here with Dr. Rizul Natiani and Dr. Army Harper. If you want to introduce yourself, Rizul.
Yeah, for most of you guys listening, you already know me. I have been hosting a couple of my podcasts with our new editorial as well as our general board team. And this is an opportunity for Zoha to take over and introduce Dr. Harper, but it's a wonderful opportunity to get to know something new in this episode.
So I'll go ahead and get started. Dr. Harper is a renowned ophthalmologist specializing in retinopathy of prematurity, a condition that affects premature infants and can lead to blindness. He's a retinal pediatric ophthalmologist based in Austin, Texas. With years of experience, Dr. Harper has dedicated his career to diagnosing, treating, and preventing this condition, making him a world-renowned expert in the field. His work includes not only caring for vulnerable infants in his practice, but also advancing research and treatment protocols to improve outcomes globally. Through his practice at Austin Retina Associates, Dr. Harper has continued to combine research with compassionate care, aiming to preserve and enhance vision for his youngest patients. So I'll just go ahead and get started and jump into our first question. Dr. Harper, can you share your journey into pediatric retina ophthalmology and any significant milestones in your journey?
So first of all, I'd like to thank you for allowing me to be on your podcast. It's a wonderful thing you guys are doing, and it brings more prominence to the need for global ophthalmology, which is what I always try to promote in my residents and fellows and medical students. So it's quite an honor to be here. I started doing retina at LSU in New Orleans Charity Eye Hospital. And my mentor there was a guy named Golem Payman, a very famous retinologist. And we had some ROP, and I was aware of it. And of course, as a resident, it's kind of a nuanced thing because it's really getting down to the granular level of retina, and it almost a subspecialty within itself. And then my wife became pregnant at the time I was in New Orleans. And so in New Orleans, she went into labor at 18 weeks and went into the hospital at 18 weeks with premature labor. And basically, I was thinking about doing retina. I was actually kind of doing a pre-fellowship year with retina with payment. And I kind of made a promise at that time, if everything turned out, then I would take care of kids for the rest of my life with ROP. And that's how I got started. Was a godsend for me because KCI Institute at the time, Earl Palmer, who was a pediatric ophthalmologist, was the one who brought the cryo ROP study over from Japan. And they did all the legwork to do all the studies. And of course, as you know, that cryo ROP study was stopped early because the results were so promising. Because up until that time, we had no way to stop retinopathy of prematurity. And so it's expanded from there. And then that was kind of my journey. And when I started in Austin in 1995, I started doing retinopathy of prematurity and basically a lot of retina surgery on pediatric patients, which is nuanced in and of itself. It takes probably 5 years after your fellowship to really understand the anatomy of pediatric retina. So it takes a while to get quite good at that. It's also super rewarding for me because, again, most of the time, ROP can be stopped and we can really provide these babies with 80 years of vision. And, that's the goal for me, is to be able to help them see. And now that we have babies that are born at as early as 22 and a half weeks, it's even more and more important.
Yeah. Before we dive into the global aspect, I know you mentioned that, your own child was born early, and that's kind of what inspired you to want to treat other children. I kind of wanted to talk about some of the challenges that you face in treating retinopathy of prematurity here in the United States, and maybe some of the low income areas in the United States as well.
So there's not enough of us, even in the US, to do retinopathy of prematurity. And part of that is it's difficult. It requires very mentored training. And you
Hmm.
have to have a lot of programs don't have people that train people to do retinopathy of prematurity. And so there's really a sparseness of ROP providers in the US. It's hard to get out to all the rural areas to see people. So a lot of times we've adapted telemedicine principles. I have a satellite location that's actually 5 hours drive from Austin that I look at images every week. And we try to do more outreach. I have friends, Darius Moshfeghi at Stanford. He does remote screening for, I think, 37 NICUs. So we've tried to expand it. And then Pete Campbell at Oregon and Paul Chan at Chicago have developed an AI model that'll probably be launched in the US fairly soon to be able to read digital images with really high sensitivity and specificity to supply the guidelines for that. In the US, we're lucky. We have great NICUs. We have wonderful providers, great nurses, and we have a baby to nurse ratio. And so
Hmm.
we have control of our oxygen. So we have really, really good outcomes all over the US, luckily.
Yeah, I mean that's really great to hear that, we're progressing at home. I think people sometimes forget that there's even challenges to access in the United States. But that makes me wonder how do you see that contrasting with ROP challenges in low middle income countries that you've worked in abroad?
So it used to be that, for instance, Africa didn't have any ROP because the babies usually didn't live long enough to develop ROP if they were small, and they didn't have really good supply of oxygen. So a lot of times we just didn't see that much ROP. The other thing is the providers oftentimes weren't trained to see it before, so it was hard to diagnose. Now there are more and more babies that are being saved in Africa, and it's the
Hmm.
largest growing continent. Our birth rate in the U.S. is very, very low. Most Western countries is low, but Africa is exploding with children, luckily. But they're saving them smaller and smaller, and now we're seeing more and more retinopathy of prematurity. One of the problems there is control of oxygen, because as you guys know, hyperoxia early in ROP will stimulate retinopathy of prematurity. So even in middle income countries like Mexico, there's really an epidemic of blindness. There are 50,000 kids a year that go blind or lose vision in Mexico from retinopathy of prematurity. And it's the leading cause of blindness worldwide now. It used to be just cataracts, but all over the world, we're seeing the same problem. The medicines that we treat with, Avastin, Lucentis, Eylea, are very expensive in developing countries. And so they have hard times getting access to that. Laser, which was the mainstay of treatment for many years, is very, very difficult and requires significant mentor training. And also the lasers are expensive to get. So part of our program, what we do is we train people to recognize what ROP looks like, to teach them how to treat ROP with either injections. And then if they were lucky enough to have a laser available, then we can do mentor training with laser as well.
Okay. Yeah, that's really wonderful work that you're doing. I guess I'll switch gears a little bit, but I wanted to ask about your journey with Orbis, kind of what motivated you to join Orbis, what has been your most memorable experiences there, and if working with them has changed your outlook on how you treat ROP at all.
So it's interesting. The high school I went to in Austin, St. Stephen's, is about giving back to communities. And I think if I think back far enough, and that was a long time ago, like for instance, the founder of Tom's Shoes came from my high school. And so there are people like that coming through, and we were taught to really give back to other communities. And I think that's kind of where it started for me.
Mhm.
When I was an undergraduate at Vanderbilt, I did the Appalachian Student Health Coalition. So we went to Appalachia to deliver care, not ophthalmology. I wasn't an ophthalmologist at the time, but just basic care. And then, when I started, I was looking around, how can I better serve the people? Because I felt like we have everything in the U.S., everything
Mhm.
anybody could ever want in the NICU, or, in my clinic, we have every machine that's ever been invented for ophthalmology, it seems like. So I had some contacts with Orbis, and then the medical director is a really great guy named Hunter Sherwick.
Mhm.
And I contacted him. I was persistent because you have to be a practicing ophthalmologist for 5 years before they'll even consider you.
Mhm.
And then I had some contacts that were able to get me in with them to travel to different countries. And I went to China and Vietnam and Peru with Orbis and had a great experience. And it's a great outreach to those communities, whether it's adult retina or pediatric retina. But recently, Orbis has really pivoted toward pediatrics and pediatric retina and even premature babies in ROP. And they're doing a big push and a big program into, for instance, Mongolia is going to get that AI program started very soon to start in Mongolia to deliver that care. And basically, when I go to the different countries, people are the same all over the world. They just want to save their babies and they want them to see. I think that's the main thing that goes through the whole thing. Everybody wants their kids to see, and we just have to figure out a way to help them, let them have agency to deliver the care themselves, which is what Orbis always does. Orbis is not about treating a large volume of patients. Orbis is about teaching a man to fish. And so it was a wonderful model for me to see that and then set up my own foundation to just focus on babies. But we're still working with Orbis. So we'll go to Mongolia probably next year with Orbis as well, with Hunter Cherwick and his team.
Yeah, I wanted to ask you a bit more about your organization, Small World Vision. How did you come to establish that, and what are some of the goals that you have for the next coming years?
So it was kind of a interesting story. I was in a meeting in Mexico, and I was talking to a guy named Hugo Quiroz Mercado. Hugo was the first person who ever injected a vaccine in a baby anywhere many, many years ago. And so I knew that the rate, for instance, our treatable rate of ROP in the U.S. in most NICUs is between like 4.5 and 9%. But in Mexico, it can be as high as 40 to 45. And so I was talking to Hugo, and I said, Hugo, why is this happening? He said, well, I don't know. And I said, well, I think I can help you. And he said, how? And I said, well, I think it's because they're getting too much oxygen and there's no oxygen blenders in the NICUs. And so I said, I'll come down and we'll go visit some NICUs. So we did. We visited 3 NICUs, and indeed none of them had blenders. And that's not to say that in the private hospitals in Mexico City, their NICUs are very much like ours, but in the government system hospitals, they don't have resources. They don't have oxygen blenders. They don't have pulse oximeters. So I decided to start a foundation to be able to educate and then try to deliver blenders to these locations, which we did in Mexico. We delivered 10 conventional blenders at one point. And then I decided that these blenders are super expensive. We're going to try to create a different device. And that's kind of where we are now.
Amazing. When I think about, trying to maybe give blenders or change the status of blenders, I always think of like the underlying logistical aspects of it. And I know that usually involves quite a bit of advocacy work or policy change, whether it's in the hospital level or at the local level in Mexico City. So I was wondering, what role do you believe that advocacy plays in improving outcomes of ROP? And how do you engage with policymakers, if you have at all, in improving pediatric eye care?
So it's hard because what we say is babies don't have a voice. They don't know how to talk and they can't speak for themselves.
Right.
So the way you do it is there's a lot of grassroots. You have to educate the parents. You have to find people who are policy makers. And for instance, we're in Rwanda. I'm talking to a former minister of education and outlining the problem. And to find sympathetic ears with the Ministry of Health in whatever country you're going to. Orbis is very good at that. They've been doing it for 25 years, and they have the ears of almost every Ministry of Health. So to be able to partner with them is key for us to be able to access it. And just a lot of people don't even know that this is one of the biggest medical injustices in the world. And for instance, a blind baby in Africa has about an 80 to 90% reduction of income compared to someone who's sighted. And by teenager, if you're blind in Africa, up to 50% of those kids die. And so bringing that into focus for Ministry of Health and the costs it takes to take care of those children is huge. The economic price point of that is massive, and communicating to all these individuals and try to get them to have agency and really go forward. In Rwanda, Paul Kagame is the president. He's very, very progressive, and he wants Rwanda, Kigali is the capital, to be the shining example of Africa when it comes to healthcare.
Mm-hmm.
And you can see that they just had a Marburg outbreak in Rwanda, and they were the first one to deliver the vaccine to the healthcare workers there. And they really did a great job of handling the outbreak and closing it down. So people like that are the ones that we like to work with in different countries. And Orbis has really got, again, they have the connections to help us, and we can help them with what they want to do as well.
So I did want to ask, working with a little bit of the African continent and the countries within it, eye care is not something that is often prioritized. Do you see that having changed over the 20 years that you worked abroad?
I think it's just coming online now. And there's different organizations that do different things on eye care. And it depends on what country you're talking about because they're all a little different. Some of them have more resources than others. Nigeria right now has really a lack of resources, and it's very difficult to advocate for care. But other countries like Rwanda are more progressive. Tanzania is doing a good job also. Kenya is very advanced. And of course, South Africa is kind of the model for all over Africa right now. And it just depends on, they're all a little bit different. And so I think what you have to choose is a country that you think you can be successful in, and you can work with that different Ministry of Health, because you've got to figure out how to make the dollars that you have go towards what you want, if that
Mm-hmm.
makes sense.
Yeah, I completely agree. And I was going to echo your sentiments that you were saying earlier. I think that being, visually impaired or blind in low middle income countries abroad is an entirely different experience than being blind in, say, the United States or somewhere in Europe. Having done work in Tanzania myself, I've seen the impacts that it can have, especially on, mental health and the stigma that's in communities just because they may not know entirely like why this person is blind or what caused it. So I do think that's another challenge. And in that same route, what policy changes, whether abroad or here at home, would you like to see implemented to address ROP and improve pediatric vision?
So here it's interesting. I think you need universal screening of all babies.
Mm-hmm.
And so what that means is that when a baby's born, they get some kind of either contact or non-contact picture through a RET cam or an icon camera, or there's some developing OCTs that will do the same thing, because we can pick up different anomalies early. And if you look at some studies that have been done by Stanford, they looked in China and they found that there's a fairly high incidence of pathology, about 5% if you screen all babies, not just preterm, whether they're intraretinal hemorrhages or if we can pick up retinoblastoma earlier.
Mm-hmm.
And for instance, when you have a baby in a U.S. hospital, everybody gets screened for hearing. The outcome of that is that 3% of the children have some hearing deficit. So you're looking at 3% versus 5% if we take a picture. It's about economics and legislation. So that needs to be legislated state by state, and hopefully we'll get there. And so that in the U.S. is what I think we need. In developing countries, I think there just needs to be more awareness and education. And again, you have centers like APEC in Mexico City who are at the forefront and some of the best ROP leaders in the world there, but they still have a country in different states that are not taking care of the kids to the level that they are, where we're still having a lot of blind children there. So there's a lot of education and resource allocation that needs to be done. And it just, to make people aware of it is really a critical thing. And so that's what we're really trying to do.
Yeah, I was just going to ask if this has been discussed at mid-year forum at all.
I don't know. I wasn't there, so I can't really tell you. I try to get to as many meetings as I can, but I have to pick and choose.
Yeah.
Because I'm traveling a lot to these countries, and I try to go to the pediatric retina meetings or even to APOS if they ask me to go speak. So I didn't go to that one.
I think I certainly would love for someone like you to come to APOS and kind of speak about this, because it's something that we, talk about from a treatment side, but we don't talk about from a prevention side. And the other thing is, when you go to other countries that are low middle income, my question to you is, where do you decide the areas within those countries that you want to tackle? it seems like a really big task even within the United States, but then to go to a country that is foreign to you, I wonder, how do you try to compartmentalize and also spread out in an way?
I think that's a really great question. In Mexico, we have advocates in Mexico, and we have Mariana Martinez Castellanos, who's fantastic, one of the ROP leaders of the world. We have Judith Espinoza. We have Paulina Ramirez Neria. Judith is peds and retina. Paulina does retina and is a big advocate for babies and has a great Instagram called The Retina Doctor, if you're ever interested. And then they have been very pivotal in how to get us into hospitals, speaking with different people who are leaders in Mexico to try to get there. For instance, in Nigeria, we went with Stop Infant Blindness Africa, and they had some connections to the hospitals in Port Harcourt, and were able to get into those places. In Rwanda, my friend Brandon Hadfield is a neonatologist, was trained at University of Texas San Antonio, and he's in charge of the only neonatology fellowship in Rwanda. So it was very easy for me to say, hey, Brandon, let's go see all the hospitals in Kigali. And so we went to every one of the NICUs in Kigali with him because he trains all the neonatologists. So we're also sponsoring, they have just started their ophthalmology residency program in Rwanda from the government. And so we have provided them all the basic science books. Also, they have access to the University of Texas library of all lectures that we do for the University of Texas at Austin, trying to help train the next generation. So when I go back there periodically, I always lecture to those guys, trying to get them interested in this nuanced, pediatric retina portion of it, or even ROP. And we like to work with people that we're going to feel like we can be successful working in. And then we always pivot off of Orbis if they'll let us. And I helped edit and write the ROP guidelines for Orbis with Linda Cherniciaro and some folks from Peru.
Mhm.
That is a fantastic guide for them. So we try to do things to make connections. My job within the nonprofit and the other company that's developing the blender is I'm the connector of all the people, trying to connect everybody and find advocates in every state or every country that we go to, if that makes sense.
Yeah, I'm almost wondering if you feel as if there's a need to have more retina pediatric specific fellowships throughout the country. I feel like that could make a huge change. You mentioned mentorship before, and I think, that would be a really great way to have a sustainable mentorship program for years to come.
Yeah, and I think it's hard because if you have a small program, you're not going to get the volume. But I mean, you have programs like Nina Baracol at Bascom, who's arguably one of the best retina surgeons in the world, not only in pediatric retina, but elsewise. And then you have a Royal Oak with Kim Drenzer and Tony Capone and Mike Tracy, who's deceased, but really started that program that are training the best people in the world. And you have Casey with Pete, who's training people. The surgery part of it's harder, I think.
Mm-hmm.
It's also interesting because, with us, we have 3 fellows right now. We have 2 second-year fellows and a first year. And I have responsibility for 12 or 13 hospitals that I do ROP in. So they make rounds with me every Sunday.
Okay.
And so we do 5 or 6 hospitals on Sunday. And
Mm-hmm.
so people that are applying for fellowship know we have that retinopathy of prematurity component. And then Edward Wood, my partner who trained at Stanford and Royal Oak, is fabulous. And he does pediatric retina surgery, as do I. And then Ryan Young, trained by Baracol, also does pediatric retina too. So we have a really big cohort of people who are concentrated just here in Austin, which is arguably a small community compared to New York or somewhere like that. You can find pockets of it. In Houston, we have, Manny Chang and Preeti Rayo, and they're fantastic. And they do train some people in their fellowship as well.
Yeah, I mean, that's amazing. And I hope we can have some more in the future. I know we're kind of nearing the end of our episode, but I wanted to ask, how do you see the landscape of pediatric retina evolving, especially with global initiatives? Are there anything in particular that you're very excited about that you think could really transform the field? Or anything that you think is needed immediately. Just wanted to hear your thoughts.
So yeah, two things. One is I think the AI program for Pete and Paul is arguably going to revolutionize everything because it recognizes what's going on. It can predict treatment 2 or 3 weeks out of when they're going to need treatment. That's one. Orbis is training people. That's two. It's super important to be able to train. Injections, they're daunting, but they're not hard. And so that's something that can be trained pretty easily by either you can train doctors or nurses in those countries to actually do that. Sarah Rodriguez, who's a pediatric ophthalmologist in Chicago, Els, who's peds and retina in Calgary, have been really advocates of that. And Mike Blair, my other friend from Chicago. And then lastly, our oxygen blender that we're creating that will run off of only tank oxygen or forced oxygen, but no forced air for our O2 Science oxygen blender. That one, if we can get that launched, I think it will revolutionize not only ROP, but it prevents stuff from happening. Whereas with the treatment, yeah, we can treat them, but if we can just prevent it and lower the rate by a significant amount, it will be tremendous.
Yeah.
Those are the three things that I really see as advancing. Hopefully we won't have to do much surgery because 4 and 5 retinal detachments are super difficult to do. And I see a lot of those in Africa, and they want me to come back and spend my week being tortured operating on stage 4 RDs, ROP kits.
Well, I really appreciate you taking the time to talk to us. I know the first time I heard you speak, I was incredibly inspired. I've never heard anyone really combining the two. Like, I know pediatric ophthalmologists that do ROP screenings, and I know a few retina doctors that will occasionally see the babies, but I've never really seen the two combine, and it's just amazing. Rizal, I don't know if you have any last thoughts or questions.
Yeah, no, I 100% agree with Zoa. I've seen how RP is treated with the lasers, and it can be a pretty daunting task. Sometimes it can take, more than 30 minutes standing and scrunched up and, trying to make sure that these babies eventually recover and do well when they grow old. I did have a question, Dr. Harper, before we leave off this conversation. We talked about treatment, but how do these babies end up doing? I think from personal experiences, maybe you can kind of share how RP affects a child as they grow and how those treatment or interventions help them going forward.
So ROP is a lifelong disease. We know that, we in the United States, we do a great job of treating these kids with anti-VEGF. And then you have to be careful because, again, you're going to stop the progression of blood vessels. So we always do a fluorescent angiogram at about 60 weeks to look at the kids to make sure that they're not active, and laser if they are at about that time. But they need to be followed for the rest of their lives. They can develop lattice. They can develop myopia. Some of them have visual field defects. And, in the cryo-ROP study, even the ones that weren't treated had visual field defects. So they need to be, it's a lifelong thing where we work hand in hand with our pediatric ophthalmologists to make sure that everybody's on the same team and we have a really good relationship with everybody. We're trying to provide them with that vision for the rest of their lives. But I think the advent of anti-VEGF has lessened the myopia and the severe thick glasses person that we used to always see. But sometimes laser is still indicated. I lasered a baby just the other day it was a 22.5-weeker that we used anti-VEGF twice, recurred. So then we ended up lasering. So there's definitely a role for it. But the main thing I can tell you about ROP is vigilance, because the ETROP study was really an older study. So those were babies, they didn't have many babies less than 26 weeks old. And now we have many, many more that are very tiny. And so those need to be watched a little differently than those 26 weekers. But it's a lifelong disease, and that's what we counsel the moms and dads. But most of the time we can get them to see, and that's the goal.
Wonderful. I think this is kind of a treat, having spent some time doing pediatric research this past year, and then I'm going on to learning about ophthalmology during residency. And so I think, this was a really nice setup and request for Dr. Harper to be on the show and share something new that we haven't explored.
Yeah, I completely agree. Thank you so much.
Thank you, guys. I was really honored to do it, and to call me anytime. Okay.
Absolutely.
Take care.